Good afternoon, everyone. Thanks so much for joining us today. We'll get started in just a moment, but we'll give folks a little extra time to get logged in and get settled here. Alrighty, good afternoon, and thank you again for joining us today as we discuss CMS's 2026 Physician Fee Schedule and Quality Payment Program Proposed Rule. Before we get going, I have just a couple of housekeeping items. First, the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. Secondly, if at any time during the presentation you have questions, please feel free to drop those in the Q&A chat, and we will try to leave some time to answer those at the end of today's presentation. Here's a look at our QPP team here at the REC. Presenting today will be myself, Jared Deason, and I'm joined by my colleague, Jessica Elliott. Folks, we have a lot to cover in our hour together. We're going to start off, I'll kick us off by reviewing proposals to traditional MIPS and MVPs. Jessica's going to dig into some of the proposals around APMs and Medicare Shared Savings Program. We'll discuss important elements that fall outside of QPP. And lastly, we'll review overall impacts and highlights that you should be aware of with this proposed rule. Here is CMS posting for this proposed rule. This rule was dropped in early July. We have included here on this slide links to the rule itself, as well as the fact sheets to the various areas that this rule covers. All right, let's jump in and take a closer look at what CMS is proposing for traditional MIPS and MVPs. Starting off here with the participation tracks, nothing really new here or no changes with CMS's goal or plan of moving from a fee-for-service model of care to a more value-based care-centered model. And this is CMS's avenue to really get there. The QPP program is designed to move clinicians from traditional MIPS into advanced APMs and gradually assume more and more risk for their own cost and quality. As you move from traditional MIPS along MVPs, along the APP, and eventually into APMs, you're essentially doing a few things here. You're focusing your measures and activities to be more closely aligned with the type of care that you provide. You're putting more skin in the game as you move across these tracks and working towards that full capitation model. And you're balancing your quality of care with the cost of care. Most of us are still participating through this traditional MIPS track, and that's totally okay. But as we start to see more vendors support MVPs more, we have seen an uptick in interest in MVPs, and we're really excited to help you guys take that next step. Moving over to basics of traditional MIPS and MVPs, I'm happy to say that there are no proposals to change category weights, payment adjustments, or low volume thresholds at this time. A final score of 75 points is still that target for a neutral payment adjustment, and that's been proposed to remain at 75 through calendar year 2028. Low volume thresholds will remain at 90,000 Part B billing, 200 Medicare beneficiaries, and at least 200 covered services. CMS is maintaining the automatic PI reweight for special statuses, and there were no new eligible clinician types proposed in this rule as well. Where we start to see some of those changes is within the quality category. There are 5 new measures proposed, 10 measures proposed for removal, and modifications to 32 measures in this rule. Of the 10 measures that are proposed for removal, 2 that really stand out to us that your practice might be using is the screening for social drivers of health and the adult COVID-19 vaccination status measures. The hospitalist, radiation oncology, and optometry specialty measure sets also had substantial changes proposed in this rule. CMS is proposing modifications to scoring for 19 quality measures that were previously deemed topped out measures, and if finalized, would be eligible to receive that normal 1 to 10 point scoring. The biggest thing to note is the proposal to change administrative claims scoring methodology. CMS wants to mirror the cost methodology they adopted last rule cycle, and assigning a medium score worth 7.5 points, and then adjusting scores up or down based on standard deviations away from the median. This really means is this is a good change for those larger organizations that typically pool these administrative claims measures and should see more favorable scoring than in years past. As we jump over to the promoting interoperability category, it's also seen its fair share of proposals, but this is mainly to align with previous rules made for the QPP program or other regulatory rules that have been released earlier this year, such as the HIPAA privacy and security rule. SRAs are getting a second attestation statement to attest to have implemented security measures to be compliant with that new security rule. CMS is currently working on updates to the measure specification sheets that will be released on the QPP resource library. This proposal also aligns with changes proposed in the IPPS rule as well for those of you that work with our hospital PI team. Safer guides got updated earlier this year, so there's a proposal in there to use the newest 2025 version of those safer guides. This version can be found already on the ASTP ONC website if you're looking to get a look early at those. There's a lot of changes proposed with public health objectives. The first one being TEFCA has been proposed as a bonus measure for public health reporting, adding additional chance at some bonus points in the PI category for using TEFCA to submit public health data to public health agencies. Eligible clinicians will need to be in that option 2, the validated data production phase, to use this bonus measure. ECRs also proposed to be suppressed for 2025 reporting, and this is a big one. This is in response to the CDC temporarily pausing electronic case reporting registration and onboarding for new healthcare organizations. I do want to note that if finalized, you will still need to attest yes or no to ECR reporting. If it's left blank, it can result in a 0 for PI. If this proposal to suppress ECR does not get finalized, CMS is encouraging those affected by the pause to take the exclusion for this measure. We highly recommend that you reach out to your KHI outreach coordinator to discuss how this affects you and your practice, and finalize your documents to be in that validated production phase as that is going into effect. Looking at changes for improvement activities, there isn't too much we didn't expect here. 3 new activities were proposed, 8 proposed activities for removal, and 7 activities were proposed with modification. There's also a new subcategory being proposed, the advancing health and wellness subcategory, with the focus on mental health and chronic disease prevention and management. Along with that, the achieving health equity subcategory is being proposed to remove. Some of these activities that fell under this subcategory are being retained. They're just being moved over to the other subcategories. The highlights here are really that CMS is focusing on activities that demonstrate improvements and are more measurable. It's really signaling to us that CMS might try to make that jump to numerator denominator reporting for their measures in future rulemaking cycles with improvement activities. One too many. Alrighty, and as we jump over here to the cost category, we are getting some welcomed proposals this year. The biggest one being around total per capita cost. This proposal is to remove APPs and their candidate events from the methodology, the attribution methodology. CMS has found this to be the trigger of TPCC for specialty groups because these providers do not have that specific specialist billing code that goes on claims. This would further reinforce this measure to represent primary care providers. Um, we did not see any new measures proposed and none that are currently being field tested, which really kind of indicates a slower progression of new MVPs being created. In this rule, CMS is also proposing a 2-year information-only period for new cost measures that would provide eligible clinicians with a score and feedback for those new measures, but would not affect their final scores or be reported publicly like other cost measures are. This would give clinicians plenty of time to approve upon and plan for cost measures that could be attributed to them before this it affects their scoring. Moving on to MVPs. There we go. Um, there were 6 new MVPs proposed in this rule. They are diagnostic radiology, interventional radiology, neuropsychology, pathology, podiatry, and vascular surgery. There were also proposals to modify all existing MVPs, and this is really just to align with some of their other proposals to remove, add, or modify specific measures in each category. CMS is proposing to update some definitions within MVPs as well, specifically for single specialty groups, um, being those that focus on one specialty type, or this is new with the proposal, one clinical focus of care, and multi-specialty groups, 2 or more specialty types, or multiple areas of care. There was a proposal for self-attestation at registration to determine a group's specialty status instead of using claims data like we've previously done, um, and a proposed flexibility for small practices to not have to form subgroups and can participate as those multi-specialty groups. This really helps encourage those small practices to participate in MVPs. And lastly, an extension was proposed for QCDRs and qualified registries timelines to support MVPs. Previously, QCDRs and qualified registries had about 3 months to be able to support a new MVP after it was finalized. This timeline now extends that out to a year to support those new formed MVPs. Alrighty. So let's take a look here at what we here at the REC think are top 10 impacts within the QPP rule. I really believe that the PI changes are going to be pretty substantive and what are really going to affect most of us if they're finalized. The possibility of ECR being suppressed is a nice ease of some of that burden and challenges and overall confusion we've seen around the public health reporting measures. TEFCA is a welcome site for public health reporting as well, but you're going to really need to be thorough when setting up or reviewing with your vendor to make sure that you meet all of the proposed criteria to get those bonus points. As we look at the safer guides and the new SRA requirements, these have implications that can add to that burden of submitting for QPP and add some work to the as you're submitting for the PI category. Jessica, do you want to jump in and talk about some MVPs?
Sure, absolutely. So as you have on the slide here, talking about subgroup formation, multi-specialty reporting, as previously finalized I believe it was, I think maybe the 2024-2025 final rules, CMS has indicated that subgroup formation for multi-specialty practices is required moving forward. And so one thing that had been really unclear was what's going to happen for small specialty practice or small practices. And CMS has not forgotten about our practices with 15 or fewer eligible clinicians. And so they are going to have a carve out. So if you have more than one specialist type as a part of your small practice, you would only have to report as a multi-specialty group. So you kind of fall into that single practice bucket. And you would, despite having multiple specialties. So they're including some flexibility to help ease that reporting burden if you're a small practice. If you are a larger organization, meaning that you have greater than 15 eligible clinicians tied to your 10, you are going to be required to form subgroups. And CMS still hasn't defined or made mandatory how subgroups form. But if you are providing similar care uh, formed around an episode or a condition, if you think about diabetes care, you do have several specialists as well as primary care that do work to support those patients. And so you can have some flexibility about how your subgroup forms, but the care has to really be related and centered around a particular specialty or a particular group of patients. Also on this slide, you see 6 additional pathways, again, further trying to expand that MVP program to allow greater opportunities for our clinicians in specialty practices to have representative measures. So continuing to kind of keep out on the lookout for that. Jared did mention the lack of newly proposed cost measures. Cost measures are what builds the basis of an MVP. So you have to have a cost measure that then you're going to collect and aggregate your quality and improvement activities around. And so not having this lack is also something very important and feeds into future pathways that we're going to see. And then also kind of moving into cost, what Jared talked about with total per capita attribution. This is going to be, hopefully we're going to see some benefits with attribution being reduced from our specialist providers. A lot of times when you are in a specialty practice, you might have some APP staff, so your nurse practitioners, your physician's assistants that are creating these encounters that are adding to that episode-based count. So hopefully we will see some relief on our specialty attribution getting assigned this measure. And then also, I think, as Jared also highlighted, was that information-only feedback period, giving a two-year window to be able to look at your data, to be able to get an understanding of what this is measuring and how we roll up into that cost as an organization so that you can do some strategic planning with that measure before you get scored on it within that 3rd year of that new measure. And Jared, I'll hand it back over to you for quality and improvement activities.
Yeah, thank you, Jess. Yeah, again, administrative claims methodology. This is a really good proposal, I think, and it should be welcomed to our larger organizations. They're the ones that typically trigger these measures, and it should really lead to better scoring as we're going off of that mean methodology, or excuse me, that median methodology and the standard deviations a way to determine your scores. Um, Talking about improvement activities, we continue to see the shrinking of the inventory list. And this is a trend that I really would expect to see in future rulemaking continue. If an activity is not necessarily leading to demonstrated measurable improvements year after year, it's likely going to find itself on that list of measures to be removed. The new subcategory, though, shows CMS's commitment to addressing um, and preventing behavioral health conditions and chronic disease management. And with that, Jess, I'm going to pass it over to you to take us through some proposals about APMs and Medicare Shared Savings ACOs.
All righty, thank you very much. Good news, we don't have a whole lot. CMS thankfully this year has not decided to revamp the program. So we don't have a whole lot of changes, but I do want to call out for any of our folks that are a part of shared savings or who are a part of a MIPS APM outside of MSSP. CMS has made some updates to both the APP and the APP plus measure sets to go into effect here starting this year or this coming performance year. So CMS is proposing, as we mentioned earlier, they had finalized the APP plus measure set for 2025. That is continuing forward. However, they've made a couple adjustments to this APP plus set. Remember, APP plus is mandatory reporting for those practices and organizations that are a part of an ACO. And so that is a Medicare Shared Savings ACO, I should say. And so they actually did remove for 2028 implementation the screening for social drivers of health, again, to align with other CMS programs. However, they have left everything else that track to expand to the universal measure set. They have left that gradual implementation in place. And so we'll see that original APP set expand every year through 28. CMS is also doing some updates to the different versions of measures across both the APP and APP plus measure sets. You're going to see that they're going to align the MIPS measure versions around depression screening and hospital readmission rates for patients with multiple chronic conditions. And then they are, and so by nature, that's also going to be impacting some of these MIPS measures. So we've seen some updates from quality around breast cancer, colorectal cancer screening, depression screening and follow-up, as well as that multiple chronic condition measure. So as CMS updates their inventory for the MIPS program for quality measures, you're going to see those impact and trickle down to the APP or APP plus set. And then again, because screening for social drivers is getting removed from MIPS, it's also carrying over, as I mentioned, to future APP plus measure sets. Now, for advanced alternative payment models. So the advanced alternative payment models is that next step. So you have a much higher rate of shared savings or shared risk. There's multiple different kinds of models. Medicare shared savings, Track E, as well as enhanced are considered advanced alternative payment models. And so one of the biggest things that CMS has done this year, they've previously proposed it, but it didn't get finalized, was to make individual QP determinations. And so this happens in the case of if a APM entity itself does not meet thresholds to be considered an advanced APM, CMS is going to look at individual providers that are a part of and roll into that ACO to see if across other payers or at that individual level, that provider meets the qualifying participant designation. And so you may see some additional providers become QPs. Previously, they would receive a lump sum bonus. Right now, the way the legislation is written, they get a 0.75 adjustment as opposed to a 0.25 for covered services or for covered items and services. So you get a little bit more back on furnishing those particular services if you are a QP and earn that designation. And you also are exempt from MIPS reporting. Another piece that CMS has proposed for 2026 is changing some definitions around an attribution eligible beneficiary. And what this does is it actually helps bring in specialist encounters for an ACO, so that as an individual clinician, as an ACO, you have more patience to be able to achieve your threshold that you have to maintain, as well as an opportunity for those patients to go toward your QP status calculation. So essentially, the changes that they're making are helping it be a little bit easier to be counted as an eligible beneficiary that rolls up into potential QP determinations. For a medical home payment model, CMS is removing a 50 eligible clinician cap that has been in place. And so again, this will expand access for medical home models into that advanced APM world. Another couple, just a couple other little housekeeping things is CMS did set to align the QP targeted review period and the MIPS targeted review period. So they are trying to make sure that those two windows do align. No other major changes to advanced APMs. They are maintaining that high threshold of 75% of your payments need to be processed through that ACO, or you have to have at least 50% of your attributed beneficiaries attributed through that ACO. And so again, some of the things that they have put in place around individual determinations and looking at the beneficiary attribution are going to help more providers that are a part of an advanced APM hit those thresholds, because those are really lofty rates to have associated. Now, I did want to just talk briefly about Medicare shared savings. Again, this is probably the most popular alternative payment model that we have here in the state of Kentucky. This is what you're going to find most of your ACOs are participating in. And so a couple of the things that we have seen come through and is proposed for Medicare shared savings really look at agreement periods and look at how long you can stay in shared savings before you have to move on to assumed risk, right? And so risk is being on the hook to some degree for cost overruns. And so in 2025, CMS had expanded the ability for a brand new ACO to stay in track A or track B, so shared savings only non-risk bearing models, for the first agreement plus the first 2 years of that second agreement period. Because historically, if you join Medicare shared savings, you would join at track A or B. You had a limited time, about 2 years, to stay in that arrangement before you would have to progress all the way up through track D or E by the end of your 5-year agreement period. And so as a flexibility, CMS expanded that you can stay your entire time of your first agreement period in that shared savings. The reason behind that is so that you can take those shared savings and reinvest them into your population health, into being able to better manage and utilize your services to improve your patients' outcomes. Also, there was that set glide path that you would assume in that second agreement period. And really, this has been set aside to really help our low revenue ACOs, that they can have that additional time to really get their feet wet in this shared savings, shared risk environment before risk really gets on the line. And so what we're seeing proposed that would go into effect for 2027 is that you can stay. They're still maintaining you can stay in that very first agreement period for your ACO at shared savings only. So either track A or B. You can spend the entire 5 years. However, if you choose to do so, when you sign up for your second agreement period, you go straight to track E or enhanced. And that is looking at a much higher rate of risk. saving or risk overruns and risk that you would be splitting with CMS. And so that is something to consider if you are looking at becoming or forming or participating in an ACO, understanding how long you have to dip your toes in the water of shared savings versus how long before you have to move into a mandatory and a higher level of shared risk. Also, some other flexibilities that CMS is proposing is to allow within Medicare shared savings ACOs for their beneficiary level to drop below 5,000 beneficiaries during the benchmarking years. And so essentially what that means is that instead of kicking you out of the ACO bucket and the APP, it will allow you to maintain your ACO status. And what it ultimately will do is you'll have a few more guardrails around how much shared savings or how much shared risk that you can have on the table with that if you do fall below during your benchmark years, especially benchmark year 1 and 2. So overall, CMS is really wanting to push ACOs into dual-sided risk more quickly. They don't really want them hanging around 7 years in just shared savings. They want to get them into a much higher level of shared risk more quickly. And so I think this will be a big impact for our low revenue ACOs, our health system centric ACOs. We see a lot of ACOs that are managed by outside entities and organizations. Those are already being the ones that jump right into full risk. And so I think that's kind of throwing off some of the numbers for CMS because it is going to be really detrimental for our low revenue folks. Now, just a couple other quick updates. CMS is doing, again, just some little housekeeping things, trying to align beneficiary attribution with our Medicare CQM attribution. There was some misalignment with definitions, so they've cleaned up definitions. Again, to align with other CMS programming, they are proposing to eliminate the health equity adjustment. This is a adjustment that looks at the complexity, the dual eligibility ratios, and things like that, that would give a bonus to an ACO's quality score. They are going to eliminate that. They feel like it's duplicative. They are allowing some a retro to 2025 to allow for greater flexibility for ACOs to apply for an extreme and uncontrollable circumstance. So that's actually a good flexibility that they are putting into place. They are also looking at adjusting and essentially keeping it in place, the health equity benchmark adjustment. This is something that goes back into how much CMS is proposing you should be spending on your patients. And it also impacts your ability to kind of calculate your shared risk and shared loss. So it's an important adjustment and they're keeping it and they recognize it as such, but they are just aligning the language to move from a health equity over to just looking at the population in total. Another aspect is CMS is starting to hold ACOs accountable for not just meeting the alternative quality performance standard, but also the overall quality performance standard. They would need to make sure that they remain in good standing. Otherwise, ACOs, if they are not continuing to meet quality performance over a multiple year period, up to 2 years, they could move into some type of poor standing and then have to have some type of improvement plans and things like that in place. CMS has also put forth a couple RFIs. Most of these are looking at ACOs adopting FHIR, expanding their digital measurement strategy. So again, CMS is looking at this from a quality standpoint across all of their programs, is moving to digital measurement. And so they're soliciting comments for ACOs and ACO participants on challenges of data aggregation and being able to report electronically through EMRs and really be able to aggregate that data. Now I'm going to transition over to some of our areas outside of the quality payment program itself. Telehealth in particular is one that we just wanted to touch base on. Probably one of the more notable changes as a part of this is really about telehealth's provisional and permanent codes in the inventory. So CMS is actually planning or proposing to remove that distinction. And so what this essentially means is that code that is on the list, they're going to remain, but they're not going to necessarily be dependent on the extension of waivers from Congress, like we've seen since the end of the public health emergency and that particular waiver. So they are going to start looking at like what's their services on their list and future considerations. They're really pushing toward interactive two-way audio video telecommunication systems. And again, CMS is trying to do as much flexibility as they can within the confines of congressional statutes. And so really it's in order for us to fully expand and make permanent changes, or CMS to make those permanent changes, they need legislation brought forth by Congress to enact those. But whenever CMS can, they actually are trying to build that flexibility in. They are going to be streamlining some code review processes, shortening that. They are also adding some different information around physician and practitioner expertise to be able to exercise their own professional judgment on if it's appropriate for services to be telehealth services to be rendered, or if that patient needs to be seen in a virtual or an in-person environment. And so this is something that could be positively impactful to give that discretion back to clinicians as well. They are also going to be expanding some new codes on, as you can see on the screen here, to add some additional potential flexibility for the program. And now for RHCs and FQHCs, again, the telehealth flexibility does come into play for RHCs and FQHCs out there. They are going to be making some updates to certain G codes, especially around psychiatric collaborative care model, and unbundling the services around that with the communication technology-based services. This unbundling could potentially lead to some additional denials, rejections. It might lead to some more detailed claim audit, some staff training that may need to be considered as well. CMS has also, again, put in around telehealth that virtual direct supervision. And part of that is that a supervisor must be immediately available. And so that can bring in some logistical considerations as well, making sure that that is maintained and that that direct supervisor for that provider has to have that reliable technology to be able to access it as quickly as possible. Now, with some of the time that we have left, I do want to talk a little bit about the ambulatory specialty model that is proposed from CMS. This is a very significant piece of the proposal. And if this does get finalized, or in part, if some of these pieces do get finalized here in November, we will be providing you much more in-depth analysis and strategy around participating in this particular model. The ambulatory specialty model is a mandatory model. It's going to be based on randomly selected CBSAs or core-based statistical areas. You may be familiar with CMS's team model that was released last year. It's a mandatory model in certain regions that were pre-identified. This is going to be somewhat similar in that same vein. It's almost like a hybrid of MIPS, MVPs, and APMs, kind of all rolled up into one. This model is going to focus on two different cohorts. It's going to be looking at episode-based encounters around heart failure and then around low back pain. So there are two separate sort of offshoots of this specialist model. And it is, excuse me, again, as I mentioned, it's going to be regional selection criteria. So CMS is going to look at providers who are attributed to either of those two models, right? And so it's going to be a clinician level model. It's not going to be group reporting. It would be individual providers reporting a set measure set around heart failure and low back pain, as well as being scored on that particular associated cost measure. We are right now, CMS has said that as if proposed, they are going to be selecting 25% of all CBSAs across the state to participate in this model within year one. And if you're within that core-based statistical area that gets selected, 40% of all of those applicable specialists will actually be rolled up into mandatory participation for this model. And so you can see on the right-hand side of the screen, the way they are going to be looking at individual participants is really going to be based on your specialty claim codes on your Part B claims. And so it's only going to, for heart failure, they're only going to bring those providers who utilize like the plurality of their specialty codes would just be cardiology. So they're not going to bring in EPs. They're not going to bring in cardiothoracic surgeons or anything like that. It's truly just billing that cardiology specialty code when it ties to heart failure. And then low back pain, you're going to see that that actually rolls up into a larger swath of providers that could be involved in treating low back pain and be scored on that particular cost measure. And so that could include anesthesia, anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, and physical medicine and rehab. If your providers are billing those specialty codes, you would want to be on the lookout for this particular model and any type of reporting obligations that could come through if those core-based areas are selected and your providers would trigger. One thing with this is they are excluding non-MD, non-physician practitioners. So there won't be PAs or nurse practitioners that will roll up into this. This would be physician practitioners only. Now, a little bit more about the structure itself. As I mentioned, it's really a hybrid model of MIPS, MVPs, and APMs. There is risk on the line for this particular model. You're going to have improvement categories. You're going to have cost. You're going to have quality measures that are built around each of these different cohorts. Improvement activities and promoting interoperability is a part of this model, but it can only hurt you if you don't do well. Just by meeting the objectives fully, it does not positively impact your score like we see with the MIPS program. So quality and cost are going to make up 50% of your total score in this structure if this goes forward as proposed. And so if you don't meet your improvement activity requirements, you have two activities that they are proposing. If you only report one or can only meet the data completeness of one, then you would lose points off of your score for not fully meeting improvement activities. Again, they're going to be focused around those two chronic conditions. So they have that concept of an MVP. MVP measures, though, are, you can pick the measures that are most applicable to you or that you have the ability to report. Right now, the way CMS has proposed this, you have a core measure set. And just like with the APP or the APP plus measure set with our MIPS APMs, you would be a mandatory reporter for all of those measures. And if you don't report a particular measure, you would have points deducted from your quality score. So we are not seeing that flexibility of measure reporting in this particular proposal. And again, risk is factored into a part of this. You're going to have escalating downside risk across performance years. You also have the opportunity to be able to earn some shared savings. Everything will sort of roll up into a shared savings pool. So as you have, just like with the quality payment program, it's budget neutral. So those who are drawing a penalty actually fund the pot for those who are performing above average. And so this is CMS's way essentially to make sure that they get some cost savings out of this, and then will ultimately sprinkle down those cost savings to providers who meet those quality and cost parameters that they are proposing with this. And so you can see that the first year of this program starts in 27, and it would run through 2031. So you're going to have your initial selection period for 2027 mandatory participation. And then for 2028, CMS is going to reevaluate other providers and see if other providers should be pulled in based on their performance around heart failure or low back pain triggering for that particular measure. So ultimately, CMS out of this really wants to improve specialty accountability for care. I think in a lot of ways, this is something that we're going to start seeing more and more of. Right now, they're starting with these two measures because they are some of the highest cost measures that CMS pays out for annually. So I think that's really why they're starting out where they are with those two. And CMS has for years looked at a lot of managing heart conditions as well as low back pain initiatives to reduce costs around that. So again, as proposed, I think there's a lot of things that we would need to consider and look at here in the state of Kentucky, looking at especially if you have cardiology or any of those other specialists that could be potentially contribute to the low back pain measure. We want to make sure that, we'll have to start looking at how you can report. Right now, as it's proposed, you would have to submit measures via EHR and registry to be able to meet that specialty measure set. It'll be interesting to see what comments come through on that one. As well as you're going to see more coordinated care activities. The improvement activities are much more intensive. They are more intentional as well, kind of aligning with what Jared had talked about overall with improvement activities. This particular model really does put that in place. Right now, they aren't proposing numerator denominator performance rates, but they are really signaling for very intentional activities that do require significant involvement. Same thing with quality, really getting your specialists. That's going to be a huge component of this, getting your specialists into that QI mindset and being able to focus on targeted quality measures to move the needle with them. Another component is collaborative care arrangements. This is right now proposed to be an important part of the model, where you would be partnering with outside organizations and signing these collaborative care agreements. You have to have at least one in this proposed model. So I think, kind of looking at this high level, we're going to have to, CMS really wants to figure out a way to integrate specialists. And this is really their way of forcing the hand for ACOs, as well as in larger multi-specialty healthcare organizations, to make sure that specialist data is a part of scoring and consideration, and that they have, some skin in the game. CMS also has signaled for years that they want to find a method for provider level reporting and provider level accountability. Because this is not, group submissions are not a part of this. It is individual provider submissions of data. That is how I think this is how they're dipping their toes in the water with this. Another component that hasn't been brought up yet is that this would apply and override, if you are a part and you're selected for this model, this would override MIPS, and it would also override your MIPS exemption by being a qualifying participant. So you would still have to, despite your qualifications for MIPS or QPs as an advanced APM, you would still be required to participate in this ASM model if you are selected for it. That also means, too, that if you are a specialist and you have never had to report for MIPS, you could potentially get selected. for this model. And so if you've never had quality reporting before, that type of requirement, this could be a very new program for you. I do expect that this could add to a significant reporting burden for larger organizations having to do individual level reporting for their clinicians that would fall into this model. Now, CMS is proposing that they will have the CBSAs, that service area, identified by December of 25. So the regions of the country that will be selected. And then in July of 26, they anticipate that they would have the participants, the individual clinicians within those CBSAs that would be required to report. And then you would have 6 months essentially after you've received notice that you would have to participate and get ready for 2027 attestation. So a lot going into ASM. We will keep a very close eye on this, and we will be in communication with all of our clients. We will post resources and webinars when we find out what this future of this program is going to look like. So with that, let's do a couple quick takeaways from these impacts outside. In particular, I think advanced APMs, that's going to be fantastic as far as expanding that beneficiary population to be able to get more specialist inclusion, allowing more organizations to reach that QP status. That's essentially what's helping to meet CMS's goal of moving more folks into that model and expanding that definition, making it about covered professional services instead of E&Ms, will help achieve that. I do think a big point of concern is if you're a part of, or if you're looking at joining Medicare Shared Savings, you are going to have to go potentially from track A with absolutely no shared risk, all the way to track E or track D, assuming a significant chunk of risk from the first to the second agreement period. So I think it's going to be really critical that if you are in track A, or if you join an ACO in track A, that there is a steady plan to, during that first performance agreement or that first agreement period, to really get a plan in place to start moving up those tracks before you get to your second agreement period. We're also going to see that we're going to have some more beneficiary population, some flexibility around that with removing that $5,000 minimum, or excuse me, 5,000 patient minimum. And that'll help, that'll impact some of that shared savings and risk caps for them. But overall, I think it's going to add a little bit more flexibility for the program long term. And Jared, do you mind to finish us out through the rest of these key points?
Yeah, absolutely. So with telehealth, we really saw some positive proposals. CMS is really taking strides in the right direction for everything that they can control, especially with the direct supervision policies, allowing those to remain permanently with the remote option when applicable to do so. But unfortunately, with telehealth, just so much is controlled by Congress and tied up in legislation. And what we've really seen since the end of the public health waiver is that constant cycle of renewals in the last hour. So until Congress, somebody in Congress wants to take a stab at it, we're really kind of stuck in this renewal model with some of the most important pieces around telehealth. And then here, number 5, the proposed mandatory ASM models. This is, again, Jessica did a really good job of explaining it, but it's something that can have major implementations, excuse me, on our specialty providers. There's large considerations with performance monitoring and drastically increasing the burden on clinicians as it looks at EHR, registry measures, there's collaborative agreements, as well as reporting on top of other quality reporting programs. And as Jessica mentioned, it is something that we anticipate to see more of these ASM models for different conditions come out in later rulemaking. Um, and it can affect your non-MIPS clinicians, which adds another layer of complexity. So it's definitely something that we're going to keep our eye on here at the REC. But if you fall into these two condition groups right now, it's something that you really want to keep your eye on and reach out to your advisor about. And finally, I just want to point out that CMS has been removing some of the explicit language around health equity and social determinants of health in their programs. We've seen this trend not only here, but in the IPPS rule as well. And as priorities shift more towards prevention and chronic disease management and improving overall quality of care, that said, it's important to recognize that health equity is still very much a focus for CMS. The difference is they're framing it under broader goals of quality improvement and cost reduction, on the idea that improving care for all beneficiaries will also reduce inequities and raise the quality of care across the board. So while the wording may have changed, the work to address health inequities in our communities remains just as crucial.
Thank you, Jared. I appreciate that. And I do echo Jared's sentiment around health-related needs screenings. While we might not have those measures that are mandatory or required for reporting, I think it is beneficial to continue to keep momentum around the work that that has been done already, because we know that that's such an integral component to improving a patient's quality of care, quality of life, and their overall outcome. So as we start to wrap up here, just wanted to again do a quick recap of some of the requests for information. CMS is really kind of forecasting and asking for some feedback around with MVPs, creating mandatory measures that are reported within an MVP. So almost kind of echoing the ASM model that they're proposing. It might be a subset of measures with a little bit of flexibility, but creating some foundational quality measures, just like how PI is foundational. They also are talking about for quality RFI, so requests for information, further expansion of well-being and nutrition measures, since that is a CMS strategy and a priority right now. They're looking at expanding that out. They are also looking at not only digital quality measurement, as I mentioned earlier, but also how to hold providers accountable when they're exchanging information. And so making sure that the quality of information that they are receiving is also of a certain standard and accountability. So again, just asking for feedback on that, for promoting interoperability. They've circled this around before, but haven't made a decision on it yet, but around the prescription drug monitoring program, looking at more performance-based measure expansion. So numerator denominator reporting for the PD&P measure. Also looking at maybe some more performance-based reporting around public health and those clinical data exchange objective and measures. And again, same thing for data quality, having some parameters around data completeness and accuracy. How could they start holding providers and organizations more accountable from that standpoint? And then I believe we already discussed the APM RFIs. Again, everything is kind of in line of looking at that digital measurement strategy and making sure reporting remains aligned. So again, CMS does need your feedback. They need your feedback on your thoughts on the ambulatory specialty model. They need your feedback on some of these different RFIs, as well as the proposed changes that we've highlighted here throughout the quality payment program and beyond. And so this is our mechanism to be able to provide our feedback and our input. As an organization, if you would like to submit a comment, if you or your providers have, particular associations or other lobbying groups that they are affiliated with, they are also able to submit these. We always expect, the AMA, the AHA, to submit comments as well, but they do encourage providers and healthcare organizations to submit their questions and their feedback and propose even alternatives whenever these proposed rules come out. You do have a deadline of September 12th if you did want to, from an organization or an individual standpoint, place a comment. And then these are the 3 different pathways you can do it. Just a quick update of some reminders for our webinars. We do have a feedback report webinar scheduled for September 9th. However, CMS has not provided feedback for 2024 performance year just yet. And right now it's looking like it'll be released sometime in September. So this particular webinar, that date is looking to be rescheduled. So more to come on that, but we do want to get out some information to you all about your feedback report. Also in October, we're going to have our final part of our Accountable Care series where we're going to dive more into reporting for MIPS APMs, the advanced alternative payment model, looking into shared savings is really going to be the main topics for that. And then we're going to round out the year in November discussing attestation prep. And then in December, we will have our 2026 QPP final rule presentation. Just as a reminder, if you have not done so, our annual conference is coming up in October. Please feel free to reach out to your advisor. We are more than happy to help get you signed up. There is a client-only discount code that'll get you 50% off, whether you're attending virtually or in person. So please feel free to reach out to your provider or your advisor. And then if you do have any questions, please put those into the chat. Email me or Jared or your advisor if there's anything that you would like further clarification on. And otherwise, I know we are at time. So thank you all for your time and attention today. As always, we appreciate it. Reach out to us with any questions. We will get a copy of the slides and this recording to you all as soon as possible. So thank you all again. We appreciate it.